ISCHEMIA and ISCHEMIA-CKD, in my opinion, are trials that will have a very enduring effect. It really teaches us how we should be taking care of patients with stable ischemic heart disease. So very importantly, ischemia looked at patients that had at least moderately abnormal stress testing, who had normal kidney function defined as a creatinine clearance of greater than 30. In the ischemia trial overall, there was no significant benefit in terms of the prevention of a cardiovascular event, but very importantly, there was an important and I think very significant quality of life benefit, so patients felt better. In the ISCHEMIA-CKD trial, it really asked a similar question, but in a very understudied population. It asked in patients who have severe kidney disease, or those with a creatinine clearance of less than 30, or who are on dialysis, does an invasive strategy beat out a conservative strategy among those with at least moderate ischemia on a stress test. In the ISCHEMIA-CKD trial, there was no benefit in the clinical endpoints, but very importantly, there was no advantage towards reducing quality of life. So I think overall there is a different message in both the ischemia and the ISCHEMIA-CKD trial. Ischemia, while it showed no benefit in its overall composite of cardiovascular events, there was a very important benefit in terms of quality of life. And in the ISCHEMIA-CKD trial, there really was no benefit either in terms of their primary efficacy endpoint or in terms of quality of life. I think another very important difference is that in ISCHEMIA-CKD, among those who had severely abnormal kidney disease and who were not on dialysis, if you were stratified, if you were randomized into the invasive strategy, you were more likely to require dialysis over the long term. That's a very important consideration when thinking about bringing these patients into with a catheterization laboratory.